without wasting much time, we'll start with the first talk by Dr. Sushma. She's going to talk on update on glaucoma therapies, what's new and what's on the horizon.
Very good morning, and thanks Amit and APAO for the opportunity. Although it's a difficult task to complete update on glaucoma therapies in few minutes, I'll try my best. I'll talk in these four things that in segments that what about newer drugs, the drug delivery systems, gene therapy and neuroprotection, and road to next generation. Well, we do know that IOP reduction is possible by these three mechanisms, and we have age-old drugs who help us do that, largely decreasing aqueous production and increasing uveoscleral pathway. Few drugs also increase the trabecular meshwork outflow. And now we are looking at the newer drugs. Well, the newer drugs in the market are triple action Rho kinase inhibitors or ROCK inhibitors, they're popularly called as. They're supposed to work by all three mechanisms by increasing outflow, reducing fluid production, and lowering episcleral venous pressure. They have been used for endothelial healing in Fuchs endothelial dystrophy with our cornea colleagues. They are supposed to have neuroprotective, vasoactive, and anti-fibrotic activities, although it looks too good to be true, but then this is what the mechanism of action is. And most common side effect is conjunctival hyperemia, and both these drugs are available in India, Ripasidil and Etrasidil, and we've been using them. Now, the next on the line is Rho kinase inhibitors and prostaglandin analog combination. Those are fixed combination with Etrasidil 0.01 and 0.02%. There have been studies to tell us that the reduction, IOP reduction is as good as 30% or more. And there have been two trials, Mercury 1, 2, and 3 in Europe for safety and efficacy of these in POAG and OHT patients. So the combination does improve the compliance as well as efficacy. Another drug on the market is latanoprost Bunod. That is nitric oxide donating prostaglandin analog. So prostaglandin part of it, that means latanoprost acid binds to the FGA receptor and increases uveoscleral flow. And the nitric oxide causes vasodilation and smooth muscle relaxation, and that's how it works. The other one is EP2 receptor agonist, that is OMDI 0.002%. Well, for this, the trials have been there to establish non-inferiority as compared to latanoprost. Not available in India, approved for use in Japan, Singapore, South Korea, and these areas. Coming to the drug delivery systems, there are different ways the drugs can be delivered in the eye, which can be sustained release so as to avoid the topical regular installation. So punctal plug delivery systems were the first to come in picture. So these are the plugs that are used in dry eye patients, so they're close to the eye. So travoprost and latanoprost punctal plug delivery system have been explored. However, there are possibilities of epi4 irritation and not so constant drug release, so they've not been very popular. They are pharyngeal delivery systems like rings, which can be put in the pharynxes, and the drug release happens by diffusion, dissolution, or erosion. And here also, bimatoprost ocular insert has been studied, and also timolol and brimonidine have been useful, but still limited to animal and preclinical studies. Contact lens delivery system, because the most common thing that we use in the eye is contact lens, so drug-eluting contact lenses have been explored. And again, there are certain risks and not so regular release of drugs, so they have not been very popular yet. There are preclinical and animal model studies only yet. Similar to periocular drug delivery systems, where we have nanospheres, liposomal and gel implants, particularly latanoprost, that has been injected subconjunctivally. In rabbits, it has proved to be okay, and we are waiting for further studies there. So the couple of implants that are intracameral, which have become useful, are bimatoprost implant by Allergan, which has been used for POAG and ocular hypertension. And these Artemis trials have told us that they have efficacy equal to timolol, basically non-inferior, and the amount of complications that we've had is 6%. Similarly, another one is AIOS by the Glaucoma company, which is an implantable device and has travoprost. This has also been proven to be non-inferiority as compared to timolol twice a day, and has demonstrated -6 to -8 drop at 12 months. Again, there are certain side effects like inflammation, macular edema, pigmentation, and even endophthalmitis, because they require to be implanted intracamerally. The gene therapy and neuroprotection, largely the criteria is we can use a neuroprotective agent only if we have specific target receptors. We have lab evidence of resistance to injury. They are available at the optic nerve site for pharmacological concentration, and the neuroprotection is proved in randomized control trial. However, we do not have any such product which can be directly used, which fulfills all these four criteria. However, these are the neuroprotective agents that are being explored, that is ginkgo biloba, NMDA receptor antagonist, citicoline, melatonin, and saffron. And similarly, certain vasodilators like calcium channel blockers and carbonic anhydrase inhibitors. These have some evidence of dilation of ocular blood vessels so as to promote the ocular perfusion and have some benefit in terms of neuroprotection. There have been certain non-viral gene therapies in glaucoma, like lipid nanoparticles, small interfering RNA, and short hairpin RNA, which can be useful for silencing specific genes. There can be disruption of aquaporin 1, that is again a ciliary body protein involved in aqueous production, and AAV gene therapy has been proved in many animal models. A little about progress that we can look at the levels of biomarkers. So that's the work that we had done in terms of looking at whether there are certain biomarkers that can be useful at the trabecular meshwork level or the retinal ganglion cell levels. So what we did was almost 143 glaucoma patients and controls, and we divided these patients into severe and non-severe category based on VFI. And these patients were followed up for 1 year and divided into stable and progressors based on how the VFI progressed. And then we grouped the patients on the basis of whether they responded to the medication or not, and after trabeculectomy on 1 year follow-up, whether they required medications again or not. So aqueous humor of these patients were taken, and we studied some 52 biomarkers, and this was the result. So the markers that you see in white were higher in patients with glaucoma, and the one in orange were less in patients with glaucoma. When we wanted to look at the severity differentiation, so there were certain set of molecules that we found were higher in the severe group. You don't have to bother about the names. So just see that the amount of statistical significance that you see in certain molecules that were higher in severe group. And there were certain molecules which were higher in the progressors as compared to stable group. When we looked at the trabecular meshwork level, well, that means we could identify patients who would be progressors as compared to non-progressors. When we looked at the trabecular meshwork level or the drug response, there were certain molecules that were high in the poor IOP control group as compared to the good IOP control group with medication. That means response to medication can be judged, and there can be a drug in future which can improve the response to the existing drugs. And then we looked at the response to surgery, and there were certain molecules which are higher in patients who responded to the surgery well. That means we could also predict surgical outcomes looking at the aqueous biomarkers. So basically, to summarize, these were the group of molecules which were higher in severe group, in progressors. This was with the poor response to AGM and poor response to trabeculectomy. So these are a couple of molecules which are raised in all the groups. That means these were the bad guys that we can see. So higher in severe progression and poor response to AGM. So the future direction is that we can explore these molecules which are found to be associated with severe group progressors or non-responders, and we can use them in the clinic for prognostication and risk stratification. There can be mechanistical and preclinical studies to look at causative role, and then we can look at how we can use them in the clinic using a therapeutic target. So ultimately, the clinician delight would be that we could use the existing IOP lowering drugs with the drugs which can be enhancing the effect of the drugs, or we can do the surgery with targeted modulation of the surgery so that we can enhance the effect, and neuroprotection as well. So this is the generation next in glaucoma therapeutics. Thank you for your kind attention.